Assalamualaikum. So the topic we're given for our group is thalassemia. The case study we have chosen is about beta thalassemia major in a 5.5 years old girl. So this case study was at Cozy Corner El Ma'ava, Maldives. So the history of presenting illness of the patient shows symptoms such as coughing, dyspnea, irritability, fatigue. However, there's no fever. For the known diagnosis of the patient have been diagnosed with a beta thalassemia at the age of 2, and since the diagnosis, there's no follow-up were done. And for the family history of the patient, there's no significant history of blood disorder or genetic disease. For the physical examination, her general appearance showed a very ill-looking, undernourished, underbuilt, and a very short stature. And for the skin and nail, her skin was in ashen gray skin, whitish extremities, brittle nails, and yellow tinged fingernails. Her facial features is like a chipmunk faces, and for the oral findings, it shows a yellow tinge at the hard and soft palate junctions, a broken lower anterior teeth, a localized periodontitis, and a decayed upper tooth. For the laboratory investigation that have been done, and the result shows a CBC. For the CBC result, the hemoglobin was 4.5 GDL initially. For the peripheral smear, it shows a presence of microcytic hyperchromic anemia, anisocytosis, poikilocytosis, and nucleated RBCs. So the diagnosis confirmations, they done a HB electrophoresis, and it shows she is a beta thalassemia major, and other lab investigations such as HIV, HEPB, HEPC shows a negative result, and for LFT and RFT shows a normal result. The hospital management and treatment, for the initial treatment, she was given 3 pins pack RBCs for every 4 hours, and for the post transfusion, the HB will increase to 9.5 GDL, and after this discharge and follow up plan, the follow up is in the next 15 days. So, regarding the ferritin on follow up, she has started on iron chelator therapy. So she's were given deferoxamine 2 gram for 4 times a week, deferoxyrox 400 milligram per day, and ongoing treatment such as blood transfusions for every 20 days, LFT and thyroid function tests every 20 days, growth and development assess each of OPD visit.
Next, we want to present briefly about the disease, which is a thalassemia. So, first thing first, what is thalassemia? So, thalassemia is a group of inherited disorder in which the body does not make enough hemoglobin, causing the anemia. Typical symptoms include weakness, paleness, shortness of breath, headache, dizziness, and fainting. Next, hemoglobin is the major component of the red blood cell and responsible for oxygen transportation. The adult hemoglobin, which is hemoglobin E, is composed of 4 protein subunits, which is 2 alpha and 2 beta chain. The fetal hemoglobin, which is predominant during the fetal stage and the first few months of life, has 2 alpha and 2 gamma chain. The alpha subunit is encoded by 2 HBA genes on chromosome E16. Each individual has 4 copies of alpha hemoglobin genes, 2 from each parent. The beta subunit is encoded by the HBB gene on chromosome 11. Each individual has 2 copies of HBB gene, 1 from each parent. There are 2 major types of thalassemia, which is alpha thalassemia and beta thalassemia, but it depends on the which gene is mutated. Next, from the previous slide, we had mentioned that thalassemia have 2 types, which are alpha thalassemia and beta thalassemia. But in our case study, we focus on the beta thalassemia itself. In beta thalassemia, they have two classes of mutation that had exist, which are beta plus mutation causing a reduced production of beta globin and beta zero mutation that produce no beta globin at all. Various combination of this mutation produce beta thalassemia of different degree severity, which are classified into three groups based on clinical symptoms: minor, intermediate, and major. Beta thalassemia major result from severe beta globin deficiency causing severe anemia. In an attempt to compensate, the bone marrow tries to produce more blood cells and become enlarged and hyperactive. Bone marrow hyperactivity causing thickening of cranial bones, producing a characteristic of chipmunk face. Affected long bones can become prone to fracture and impair growth. In other compensatory response, the gastrointestinal tract absorbs more dietary iron, causing iron overload, which become more severe as the patient is treated with repeated transfusion. Abnormal iron deposit may interfere with normal function of the heart, liver, and endocrine system. Abnormal hemoglobins lead to the formation of large number of defective red blood cells, which are detected and destroyed in the spleen. As a result, the spleen is enlarged and the level of bilirubin, a byproduct of heme breakdown, increased, causing the jaundice.
So, what exactly causes thalassemia? Thalassemia is caused by genetic mutation in the genes that code for the globin change of hemoglobin. In beta thalassemia, the mutation affects the beta globin gene on chromosome 11, resulting in reduced or absent beta globin chain production. Then, we move on to etiology of thalassemia. Firstly is the inheritance pattern. For the beta thalassemia major, a child must inherit the defective beta globin gene from both of their parents. For the carrier, which is the beta thalassemia trait, is when if only one defective gene is inherited. Second is epidemiological factors. It is when a high prevalence in regions like the Maldives, South Asia, Mediterranean, and Middle East, possibly due to a historical selective advantage against malaria carrier. As shown in the diagram above, the primary cause of thalassemia is a disruption in the production of alpha or beta globin chains, which are essential components of normal hemoglobin. Under normal conditions, hemoglobin is made of 2 alpha and 2 beta chains, forming as a stable molecule that allows red blood cells to function properly. In alpha thalassemia, there's a deletion or a mutation in the genes responsible for alpha chain production. This result is an excess of beta chains, which can form unstable molecule like HbH. This unstable hemoglobin forms lead to destruction of red blood cells and result in anemia. In contrast, beta thalassemia is caused by mutation in the beta globin genes. This lead to reduced or absent beta chain production and an accumulation of unpaired alpha chains. These alpha chains are toxic to red cell precursor, causing ineffective erythropoiesis and severe anemia. And then we move on to pathophysiology of the patient in this case study. The patient presented with a severe anemia as evidenced by a hemoglobin level of 4.5 gram per deciliter, which is well below the normal range for her age and indicates a critical deficit in oxygen carrying capacity. It is also classified this as a profound microcytic hypochromic anemia consistent with the clinical picture of untreated beta thalassemia major. For the bone deformities, her physical appearance showing a maxillary expansion and also a chipmunk face. For her blood smear, they found a hypochromic and microcytic anemia. The patient's serum ferritin level was markedly elevated at over 3,500 ng/ml, which is indicative of significant iron overload. This is a common complication in transfusion-dependent beta thalassemia due to chronic red blood cell transfusion and increased gastrointestinal iron absorption. This diagram shows how thalassemia is being inherited. Thalassemia is passed down from parents to children through genes. It follows an autosomal recessive inheritance pattern, which means a child must inherit the defective gene from both parents to have the disease. Let's look at the first case. If both parents are carrier of the thalassemia gene, each pregnancy has 4 possibility outcomes. The first one is 25% chance the child inherits normal gene from both parents. The child is completely unaffected. Second is 50% chance the child inherits one defective gene. The child becomes a carrier but usually has no symptoms. Third is 25% chance the child inherits two defective genes. This results in thalassemia major, a serious condition requiring lifelong treatments. So, in this case, there is a 1 in 4 chance with every pregnancy that the child will have thalassemia major. Now, what if only one parent carries the thalassemia gene? The outcomes will be different. The first one is 50% chance the child will be a carrier, like the parent. Second is 50% chance the child will not carry the gene at all. So, in this case, there is no chance the child have thalassemia major, but they may still pass the gene on to their own children. The pathophysiology from this case is firstly about deficient beta globin change production. It leads to imbalance between alpha and beta genes. Second is about ineffective erythropoiesis. It is when a bone marrow produces red cells that die prematurely due to toxic alpha change aggregates. It is result in severe anemia from a young age, usually by 6 months to 2 years. Third is about peripheral hemolysis. The third one is peripheral hemolysis. The damaged red cells entering circulation are destroyed rapidly, contributing further to anemia. And then we move on. In thalassemia, the body tries to compensate for the chronic anemia in a few key ways, but unfortunately, this mechanism often lead to further complication. First, the bone marrow expands significantly in an attempt to produce more red blood cells. This expansion affects the bones, especially the skull and face. It results in skeletal deformities, including a characteristic appearance known as chipmunk faces, which we saw in this case. Because the bone marrow alone cannot meet the body's demand for red blood cells, blood cell production begins outside the bone marrow, especially in the liver and spleen. This leads to hepatosplenomegaly, or enlargement of the liver and spleen. These organs work overtime, but the red blood cells produced are still ineffective. Another major compensatory response is that the body begins to absorb more iron from the gut, even if the patient isn't getting transfusion. This happens because the body wrongly senses a need for more red blood cell production. The result is progressive iron overload, which can damage vital organs like the liver, heart, and endocrine glands if not properly managed with iron chelators. This will cause growth retardation, diabetes, cardiomyopathy, liver fibrosis or cirrhosis, and also hormonal deficiency.
Assalamualaikum, and my name is Nurizati, and now I will be presenting the sign and symptom and also the clinical features of thalassemia. According to the NIH, National Institute of Health, the clinical features of thalassemia are such as pale skin, yellow skin and eyes, dark urine, poor appetite, severe anemia, iron overload, and also developmental disabilities. As for the sign and symptoms, the thalassemia always caused by anemia, which is a condition that develops when your blood produce lower than normal amount of healthy red blood cells. These signs and symptoms can be include such as feeling tired or weak, shortness of breath, paleness, dizziness, and fainting, and last but not least, headache. The sign and symptom may vary depends on what type of thalassemia the patient have, and sometimes it can be no sign at all or symptom. Next, I am going to highlight some signs and symptoms and also the clinical features from the case study presented just now. In this case, the child was diagnosed with beta thalassemia, which is it shows that this patient was diagnosed at the age of 2, which aligns the typical early presentation of beta thalassemia major. This early diagnosis is common due to the severity of anemia and other physical signs that manifest soon after infancy. One of the prominent features in this case is impact growth. This child appeared underbuilt, undernourished, and also had short stature. These findings suggest the chronic anemia and possibly inadequate or delayed blood transfusion, which are crucial in managing the thalassemia. The classical skeletal deformities also were present. These include the maxillary expansion, a saddle nose, retracted upper lip, and together with this feature, it creates the characteristic of chipmunk faces, and it can be seen in thalassemia due to the marrow hyperplasia. This may reflect both iron overload and general nutritional deficiencies, as well as the effects of chronic illness. Clinically, this child presented with several non-specific symptoms such as cough, difficult breathing, fatigue, irritability. And also, this is the hallmark of severe anemia.
On to the laboratory diagnosis and finding for this patient. The initial test provide a crucial insight into her condition. Upon the laboratory diagnosis, her hemoglobin level was low at 4.5 gram per deciliter. A peripheral study revealed microcytic hypochromic anemia alongside anisocytosis, poikilocytosis, and also the presence of nucleated red blood cells. This led to an impression of hemolytic anemia, favoring thalassemia progressing into a hemolytic crisis. Further confirmation came from hemoglobin electrophoresis, which was also in favor of beta thalassemia major. Importantly, screening for human immunodeficiency virus HIV, hepatitis B, and also hepatitis C all yield negative results. Initial liver function and renal function tests were within normal limits. They continue to monitor this along with the thyroid function test every 20 days during her follow-up visits. Following her initial transfusions, her hemoglobin increased to 9.5 gram per deciliter. However, on subsequent follow-up visit, her hemoglobin was 7.5 milligram per deciliter before further transfusions. Significant findings in follow-up was ferritin level of 3,562.69 nanogram per milliliter, indicating iron overload, which is common complication in such cases.
Hello everyone, today I'll be talking about treatment and medication in child with beta thalassemia major. When the patient arrived at the hospital, her blood tests showed very severe anemia. Her hemoglobin level was only 4.5 grams per deciliter, which is dangerously low for a child. To save her life, doctor gave her an urgent blood transfusion. She received 3 pints of packet red blood cell to raise her hemoglobin to a safer level. After that, she was placed on a plan to get a regular transfusion on pin of blood every 20 days to keep her blood healthy and prevent severe anemia from happening again. However, getting frequent transfusion causes iron to build up in the body because there is no natural way to remove it. Her blood tests show very high iron levels with a ferritin reading of more than 3,500 ml. To remove this extra iron and protect her organ, doctor gave her 2 iron chelatin medicine. Deferoxamine give as an injection 4 times a week, and deferoxamine takes daily as a tablet. She now goes to the hospital every 20 days for follow-up. During this visit, doctor check her hemoglobin, ferritin, liver, kidney, and thyroid function, and also monitor her growth and development. With this treatment plan, regular transfusion, iron removing medication, and also careful monitoring, her health is now stable and much better than before. She can grow, play, and live a better quality of life compared to when she was lost to follow-up. In this conclusion, this case shows how important this is for patients with a beta thalassemia measure to get regular treatment and not miss follow-up. Blood transfusion and iron solution must always go together. With proper care, patients can live healthier life and happier life. Thank you so much for listening to our presentation.